So we've gotten through the first line, medications, and you're already getting a sense of how complicated this really is. The next high-ticket item to look at is postural hypotension. And if you look at the literature, you're going to see a lot of definitions, different definitions of postural hypotension. Essentially, it's the person goes from lying to standing, their blood pressure drops, and they have neurological symptoms. That's really the basic definition. So some people will say lightheadedness 1 to 3 minutes after standing. Well, if the person gets up, their blood pressure drops, and they're dizzy right away, you know, it doesn't take 1 minute, and I would call that postural hypotension. Then you look for neurological signs: dizziness, the weakness, the blacking out, the browning out, the heaviness, the headache, the heaviness in the shoulder area, nausea, perspiration. Look at whether when their blood pressure drops, their pulse increases, and I'll show you why that will help you work through the list. The traditional definitions are a drop of 20 millimeters of mercury in systolic BP and 10 diastolic. That's the American Academy of Neurology. I wouldn't be married to those numbers. As I said, if the drop is only 15 points, but you reproducibly create symptoms every time, I would still call that postural hypotension. So just be aware, a bunch of doctors sitting around a room coming up with a number and all voting for it doesn't mean that's reality. And be aware that this is very, very common. Maybe 1 in 3 seniors have postural hypotension. You'll have to decide if it's severe enough to be contributing to the falls. So this we've published a precursor to this list. This is a list we created to really come up with all the causes of postural hypotension, and the list continues to grow. I find acronyms help me a lot, so I was very gratified that I could maintain a little acronym, so I call this the 4D aid. So what you're going to see is the first section. There's causes with compensatory tachycardia. Those are the 3 Ds. Now the 4 Ds. I have to change that. My apologies. And lower down, you see causes that present with lack of compensatory tachycardia, and that's aid. So when you stand the person up, if they stand up, their blood pressure drops, and they have a faster heart rate, they're in the first half of this slide. If their heart rate doesn't change, they're in the second half of the slide. So you can break it down very quickly. That's somewhat simplistic. People may have problems from both, but it helps me get through the slide. So number 1 in the 4 Ds now, it used to be 3 Ds, now it's 4 Ds, and it'll be 5 Ds next time I present this because people keep on giving me another D. Number 1 is deconditioning. If someone's been lying in bed for 4 months because they've been waiting for a knee replacement, they're going to be very deconditioned. It may take weeks to months to get them reconditioned. If they've been lying in bed for 2 days after a hip replacement, they may be deconditioned, but you should be able to recondition them within a few days. So the scale of time to recondition should be somewhere around the same. Dysfunctional heart, that's the new D. So a myocardium that's not working, so a very poor left ventricular ejection fraction. So an ejection fraction, a normal one, looking at the size of the ventricle in diastole when it's relaxed and accepting blood, to systole when it's pushed out as much blood as it can, it should be ejecting about 55% of its volume. If it's only ejecting 40 to 55%, then we say that's mildly impaired. 20 to 40% is moderately impaired, and less than 20% is severely impaired. So if you have people who only have an ejection fraction of 20%, they often will not have a high blood pressure, even lying down, and then when they stand up, it really drops. And then aortic stenosis. Even if their left ventricle is working well, if they have such severe aortic stenosis, usually less than 1 centimeter squared, then the heart may just not be able to get enough blood through that aortic valve to the brain. So then you're going to have postural hypotension also. So when we examine people with postural hypotension, the one murmur we always listen for is aortic stenosis murmurs. If you have aortic stenosis and you're starting to get postural hypotension, angina, heart failure, you're within your last few years of life, unless that aortic valve is replaced. So those are end-of-life symptoms. Dehydration, that makes sense. So dehydration could just be disease. You had pneumonia, you had a UTI, you were hypermetabolic, you lost a lot of fluid, you were doing a lot of sweating. It could be dialysis. As I say, I see a lot of inpatients who have dialysis. When people receive outpatient dialysis, they do postural blood pressures before they send them home. Some of our inpatient units do not do postural blood pressures after dialysis. So when we try to get them up and walk, they're dropping, and their systolic blood pressures are 60 and 70. So because they come in sick, they're too sick to stand. Some dialysis units don't have that change in protocol that we really need. And then drugs, diuretics, so we've made people dry, or anorexic drugs. There are a number of drugs that can cause loss of appetite, but the common culprits are narcotics, digoxin. So then lose your appetite, you don't drink, and your dig level goes higher and higher. So you go into a spiral. Antibiotics, all of them, but especially the sulfa antibiotics like Septra, and cholinesterase inhibitor. So we start these cholinesterase inhibitors for Alzheimer's. We tell families, tell us if there's loss of appetite, tell us if there's weight. We write it down, we remind them, and still people come in 30, 40 pounds lighter. They've lost a lot of weight, and they have severe postural hypotension. So these drugs do help, but they are a double-edged sword. They have some really serious side effects. And then the drugs I talked about, the 6 antis, so the antihypertensives, anti-anginals, anti-Parkinsonian, the anticholinergic, antidepressants, so those would be the tricyclics, the antipsychotics, and the anti-BPH meds. So the list up till now would be causes of postural hypotension that are associated with reflex tachycardia, so your heart rate goes up to compensate to get more blood out of the heart. Then the rest of the list is lack of compensatory tachycardia. So you stand up, blood pressure plummets, and the heart rate doesn't increase. So what can cause this? Autonomic dysfunction. So you see this in diabetics who have autonomic nerve damage, so autonomic neuropathy. If a person with diabetes already has peripheral neuropathy, they can't feel vibration sensor or proprioception in their toes, they're much more likely to have autonomic dysfunction. They have the start of nerve damage. Low B12, hypothyroidism, alcohol abuse, and then you'll see this in the Parkinson's disease, and we'll go through that list of Parkinsonism. And I'll drop to the bottom drugs. The one drug that can cause drops in blood pressure without a compensatory tachycardia is a beta blocker. So we had to move that out of the other section. If you can possibly find a patient that doesn't have any of these problems, that's a very rare situation, then you'd call it idiopathic. Often what I find the idiopathic is really someone who's developing diabetic autonomic neuropathy or Parkinsonism, and they start to declare in a few years. So it's just early on in their presentation, and we can't pick up the concomitant disease. So that's postural hypotension in a nutshell. At the end, we're going to be talking about our regional geriatric program website, and we're going to try to populate it with as many resources as we can that will help you deal with things like postural hypotension. This is more the evaluation. Now we're moving into an area that, I'm going to give you a mea culpa that maybe I don't do as well as I should. So I learned a lot by reorganizing this presentation. And that's looking at gait, balance, mobility on its own. So what do? I was actually taught how to do this by my family doctor, because I asked him, what do you do? I'm already strapped for time. How do you assess balance? And, put his hand on my shoulder, and he brought me out to the waiting room, and he said, watch this, Frank. And he said, come here, Mrs. Jones. And then Mrs. Jones got out of the chair, and he described to me all the observations he was making as she was getting out, how she was using the arms of the chair, holding on to the loved one, how she leaned to the right, brought her into the room and let her sit down. So what do? I do go to the waiting room and walk people in and watch them walk, and I do a Romberg. I don't do get up and go, timed up and go in the 30-second chair test, but maybe I should. So we're going to describe these very quickly. We do want your opinion regarding whether these are useful in your practice. So this is part of the pilot where we're all learning from each other. Which of these tests are really, really helpful, and which ones are not as helpful, or are you not really interested in doing? So the Romberg test, most of us are probably very familiar with. It's not a test of cerebellar dysfunction. It's more a test of proprioception. So what's being tested with the Romberg? So when your eyes are open, you're using 3 sensory systems to keep you upright, to provide input to the cerebellum. So that's vision, proprioception or position sense in the toes and feet, and vestibular sense. So your balance center is in the middle ear. To do the Romberg, what you have to have, I always was taught, when you do the Romberg, you have people have their arms out in midair and close their eyes. That's really not necessary. It's not part of the test. That's a combination of pronate or drift in Romberg. So the arms can be by the side. So you get people to stand with their feet together. You have them close their eyes. I tend to have an arm in front of them and behind them, so if they fall down, I'll be able to catch them. So, do beware. People do fall when you do the Romberg, and it's really bad when they fall in your office and hurt themselves. So beware. You're doing this for a reason. So with the eyes closed, the visual input is removed, and you can develop some instability. So if there's increased sway, or if they fall off their stance, that would be a positive Romberg. And that does indicate some vestibular disease or posterior column vibration proprioception disease, so peripheral neuropathy. So as I said, be ready to catch people when you're doing the Romberg. Fair warning. So stand with feet together, arms to the side, eyes open. look for sway. If they're so dizzy that they can't stand with their eyes open, you can't do a real Romberg test. Then you're dealing with something else like vertigo. So you can't really do a Romberg unless they can stand steady with their eyes open. Then they close their eyes. So it's present or absent. Present if there's marked sway and you're really worried that they're going to fall, or if they can't stand in one position and have to move their feet. So you would say Romberg present or Romberg absent. The get up and go test. So that's so what we're doing is we're going from simple tests to more complicated tests that give you more and more information. So the get up and go test was developed in 1986, and I think this is what I and my family doctor do in a very informal way when we walk people from the waiting room. So essentially it's designed to assess mobility, balance, locomotor performance. It standardizes, it's an attempt to start to standardize what physicians and I are doing when we're walking people from the waiting room. So what you do is you place a straight back chair 3 meters from a wall, so facing a wall, and the back of the chair is against another wall. Have a chair that's not leaning back, that's kind of straight back. Ask the senior to stand up without using the arms for support, to stand still for a moment, to walk towards the wall, turn around without touching the wall, to walk back, and to sit down without using the arms of the chair if possible. So what are you looking for? You're looking for the speed with which they rise, whether they struggle when they're trying to get up, whether they do have to catch themselves and push themselves up. See if they're having to really lean forward when they're getting up, or whether they can just stand straight up. Look at your emotional state too. Are you ready to catch the person? If you're ready to catch the person, that's telling you something right there. When they're standing, what's their stance? Are they leaning to one side? Are they swaying quite a bit? Are they struggling to stay upright? Are they complaining of pain? Do you see them wincing when they stand up? So always do that. Always look for pain while you're doing these maneuvers. And when they're walking, look at the height and width of their steps. Are their steps regular and even? Are they maintaining their balance? If you're worried, you may want to walk beside them, ready to catch them at all times. I can't tell you how often I've caught people during some of these tests. Once again, are you worried they're going to fall? Look for some asymmetries, abnormal arm swings, hesitancy, slowing or stopping. Look at the step height, and then you might be looking at a few of these different disorders, but I wouldn't make a diagnosis based on the get up and go test. These are screening tests to tell you there's a problem or there's no problem. These are not really diagnostic tests in my mind. And if someone has path deviation, one thing that's not in here is you would also think of stroke, right? A weakness on that side. So watch how they turn. When people are turning in any mobility test, in my experience, stand on their outside. They tend to fall outwards. Right? If you're inside the turn, you'll have trouble catching them. So stand on their outside and catch them if they fall. So you're looking at the speed of the turn, the steadiness, the number of foot placements. Once again, are you worried? And I wouldn't use this. I put this in here because some people do put that there. This can give you suggestions to the diagnosis, like Parkinson's, peripheral neuropathy, cerebellar disease, but I wouldn't use this diagnostically. It's more of a screening test that there is or is not a problem. And then sitting down, look, do they descend slowly and in control? Do they just fall into the chair? Do they have to really lean forward? Do they have to hold on to the wall or the chair? And always be aware that they might fall off the chair and sit off the side, so be careful to make sure they land on the chair. So these are the general measures that we're looking for. So when they're getting out of the chair, normal would be no slowness, less than 4 seconds. 4 seconds is already fairly long. Mild abnormality, they need some assistance. And moderate to severe, they're using assistance throughout rising. They're holding onto the chair, leaning forward throughout. Standing, normal would be no signs. Mild would be a wider stance, irregular posture, just doesn't look normal. And moderate to severe would be severe trunk sway, 5 to 10 degrees, reaching out to hold on to things, doing the wall furniture walking thing. Turning, no hesitation, about 2 to 3 foot placements to make the turn. Mild deficits, 4 to 5 foot placements, and moderate to severe, 6 or more foot placements. Maybe holding on to the wall, holding on to items to make that turn, or holding on to you as you're trying to help them not fall. And then sitting down, normal would be smooth descent, not using the chair for support. Mildly abnormal, slow descent, a little hesitant, a little nervous, and moderate to severe, really having to hold on to the chair, not controlling the descent, falling right into the chair, almost missing the chair, be close to the chair, have your knee close to the chair, make sure you nudge them into the chair if they're going to fall off it. Once again, really bad when they do that during your examination. So the scoring can be normal or abnormal, so dichotomous, or it can be, you can put it on a Likert scale like this: normal, slightly abnormal, mildly, moderately, severely. So you can create your own Likert scale. The timed up and go is one step further. People are trying to make the test a bit more sensitive and specific. What they found is even the get up and go, there was a lot of variability between people doing the get up and go and how they rated it. So they're trying to create a bit more reliability with the test. So once again, it looks very much like the get up and go. They standardized the chair height here. You have your 3-meter path. You have a stopwatch. How many people here have a stopwatch? So not a lot. So that might be a little bit of a barrier to using the timed up and go. They can do one practice trial. They should wear their normal footwear, not just their running shoes, but what they wear around the house, and their usual walking aids. And you're not supposed to help them, but I would stand by them just in case. So once again, they're sitting, and you go, ready, steady, go. And you watch them go. So watch them walk the line in the floor, turn around, walk back to the chair. So there's no limit. It can take as long as you can tolerate doing the test, but after a while you might call it a failed test. So healthy people would do it in 10 seconds or less, and some very frail people can take up to 2 minutes to do it. So this was studied to look at what are the cutoffs. So as I said, the timed up and go between ages 60 and 80, the timing is about 10 seconds or less. When you get over 13.5 seconds, then you have a problem. So the outreach assessors are good at doing this test. I don't do this test in my practice, but perhaps I'll try it more often. We're really interested from hearing from the group here whether this is something that's realistic or feasible in your practice. And then the 30-second chair test. This is one I just learned about while this study has been going on. And you're going to see it's one of the outcome measures that's, or one of the assessment measures that's recommended. So you have a chair with a straight back without any armrests, about 17 inches high. You have a stopwatch again. So everyone here who's involved in this may have to go and buy a stopwatch. So we'll fund that. We'll fund that. Wow. There's a couple of dollars left in the budget, so that's good. So the instructions: sit in the middle of the chair, place your hands on the opposite shoulder crossing the list, feet flat on the floor, keep your back straight. When I say go, stand up, then sit down again. Stand up and sit down. Do it as quickly as you can, as often as you can, and do that for 30 seconds. And then what you do is you count the number of times the person goes all the way up, not part way. Make sure they're not cheating. So you're like a coach. You're encouraging them to do it the right way. Record the number of times, and if they're sort of halfway up, you're going to count that as a stand at the very end. So we are interested in your feedback on this and the other tests. So a number of ways to assess balance mobility. Don't forget, if there is a balance problem, if there's near falls or falls, don't forget the medications, the postural hypotension, and that pain control is adequate. Sometimes pain control, all you have to do is take them from PRN Tylenol to regular Tylenol, or Tylenol arthritis, a long-acting Tylenol every 8 hours. So just make sure they have regular analgesia before you go too much further on your assessment.